Well, good morning. Hopefully that microphone is picking up, I can hear. So we'll be having two lectures together on the theme of chronic obstructive pulmonary disease, which is one of the world's most common diseases, but very poorly appreciated. So many people have probably even never heard the term chronic obstructive pulmonary disease in the general community. And when communications go out for public education, very often the term emphysema is used because people understand the word emphysema more than chronic obstructive pulmonary disease. Now, I'll make a note that I've uploaded, or with Rose's help, uploaded. I badly uploaded one file in the wrong spot, but it should be accessible now after Rose's correction. There's one large file which covers two lectures, and we'll just segue through today and tomorrow. So, chronic obstructive pulmonary disease belongs to a group of diseases that affect the lung, obviously. The small airways and also the soft tissue. So this diagram shows the structure of the airway branches in the normal human lung, and on the left I put asthma. So asthma is a condition where the airways narrow excessively due to smooth muscle proliferation and inflammation, and asthma is largely reversible with current therapy. So the steroids and beta agonists that are used to treat this condition can't cure it, but can largely help to open the airways up. COPD is a much more difficult condition. Patients usually come to their physicians quite late in its course. If we go through all of the major markets where drugs for COPD are sold, the median age of diagnosis in most Western countries is about 73. So really, people come very, very late in the clinical course, and by that stage, the emphysema, which most people equate with COPD, is really very advanced, and they may have little lung tissue at all. But they'll also be suffering very often from bronchiolitis, inflammation and fibrosis of these small airways here that we can see, these delicate structures, and another condition called chronic bronchitis, which is excessive production of mucus. So it is the aggregate of all of these conditions that constitutes the term COPD, and they're actually quite different in their molecular drivers. Now, between asthma and COPD, I put this term ACO, which is asthma-COPD overlap. This has become quite a focus in current academic discussion because of careful analysis of the people who entered clinical trials for asthma or COPD. So we go through the history of how medicines are made. Key regulators like the US FDA were very determined that medicines made for asthma should be studied in patients with well-defined asthma, and patients intended for COPD should be studied in very well-defined COPD. But if we do an audit of the entry criteria, the inclusion criteria for those clinical trials, we find that they apply to less than 10% of the total number of people with airways disease. So about 90% of people have some features of both conditions. And this is really important to understand, and that actual overlap is very poorly studied. So there have been very few specific trials for the majority of people in the middle, and we'll go through this theme. So I'll go through and explain how COPD is thought to develop. This is a lung with advanced emphysema. The structure should be like this, but ends up like this. And so we have tremendous loss of airway tissue over time. Now you can imagine that when there is nothing left, it is very, very hard to produce a therapeutic benefit because there is no tissue to treat. This is the bronchiolitis shown in more detail, work from Jim Hogg, showing remodelling of the airways, infiltration of lymphocytes, B cells and CD4 cells, and also fibrosis of the airways. And this is an important distinction from asthma. Usually in asthma, the airways don't become fibrotic or scarred. There's connective tissue which is deposited, but they remain flexible and can open. This scarring mechanism here in the small airways makes them very difficult to open up because they're physically constrained by the fibrosis tissue. Also at the moment an irreversible problem. And the bronchitis is very prominent. So in asthma there is hypersecretion of mucus quite commonly because the epithelium changes from ciliated to secretory. That also happens in COPD. There are too many mucus-secreting cells called goblet cells, but there's an additional process which is that the submucosal glands, which only occur in those airways that have cartilage, proliferate massively and produce large volumes of thick mucus. And of course these glands are quite hard to reach because of their physical depth in the tissue with drugs that might try to reverse that process. So all of the processes in COPD are very difficult to reverse, if at all. I'll make the point, and we'll have a module in the lectures around cholinergic bronchodilators, which are the cornerstone of therapy. And just to make the point at this stage that all the way down the very, very fine airways, right down to the alveolar units, there is dense infiltration with nerves, both sensory but also cholinergic effector nerves, which release acetylcholine. That becomes quite important. And we find airway smooth muscle right down to the alveolar ducts, to the deepest structures in the lung, for a special reason that I'll go through. Now, these diseases, asthma and COPD, are huge global health problems. Currently, there are about 300 million people diagnosed with asthma, 300 million with COPD, an unknown number with ACO, and these numbers underestimate the problem. If we take a look at causes of lung disease deaths, taking the UK data here, we find COPD is a very, very common cause of death. It's actually the world's third most common cause of death globally, yet very, very poorly understood. And the market for drugs in this area, if you're an entrepreneurial type, is already enormous. So in 2017, about $41 billion was spent on medications for these drugs, for these diseases. But companies are wary of investing in COPD because diseases that have end-stage organ destruction, almost a priori, are very difficult to treat because there is nothing to treat. And so the clinical trial endpoints in COPD, at least for old people in their 70s, are extremely difficult to hit. A clinical trial for a bronchodilator in COPD that needs to show a benefit on something called an exacerbation or worsening currently costs between $500 million and $700 million to perform. Enormously expensive clinical trials. And so, although there is a pressing need to make new medicines for these conditions, particularly COPD, the field is currently blocked by these problems. So it's easy to develop drugs if there is a phase 1, in the early phase of clinical trials, a predictive surrogate or a predictive biomarker. A great example would be in the field of HIV medicines. We've gone from a disease that was uniformly fatal to a chronic manageable condition with HIV, and the thing that happened in the middle is that blood viral load was accepted as a surrogate. Simply showing the reduction in virus titer was sufficient to register drugs, which were later proven to extend life. So we don't have a simple surrogate for COPD. We need to move to phase 2 trials. These are proof of mechanism trials, and again the indices are blunt. In some trials, eosinophils are measured because eosinophils very loosely track with the risk of sudden worsenings called exacerbations. Exacerbations themselves, which are simply defined as a worsening in the patient's condition requiring a change in usual care, are used as endpoints, and because that definition is so blunt, you need enormous trial sizes to do it. There are quality of life questionnaires, and then the biggest problem of all is that the index, FEV1, the forced expiratory volume in 1 second, and I believe the majority of you have now done a prac, where you've done a peak flow, blown out as hard as you can, like that. FEV1 is how much you can blow out in 1 second. This is the usual index of lung function. It's the one the FDA wants to see as a trial endpoint. And the problem is FEV1 is all about larger airways. The FEV1 measurement is completely blind. It does not see the changes in the small airways that are characteristic of COPD. And this is a huge problem because the trial endpoint is wrong for the disease, but at the moment there's not a small airway function measurement that is uniformly accepted for registration purposes. And so companies are faced with the problem of doing enormously costly phase 3 programs, and then of course the medicines end up being enormously expensive to recoup the cost. So clever people in the audience should be thinking, future entrepreneurs, future investors, future scientists, how shall we change that? It's not about treating end-stage COPD in people in their 70s. As we go through the mechanisms I'm describing here, it's about identifying ways that we could help people much earlier when lung structure is preserved before these end-stage events occur. That's where the opportunity lies. And so, interesting, I spent quite a bit of my career in the drug industry. I've actually made some of the medicines that you might learn about. And I remember writing the strategic plan for a company called Ciba-Geigy, which is now Novartis, which is an enormous Swiss drug house. In 1994, that many companies in the asthma field are considering COPD as extensions of their asthma portfolios. And so what we've seen because of these clinical trial difficulties is that really the only medicines that are available for COPD are those that were originally made for asthma, bronchodilators, crossed over into the COPD area, and there's a controversial role of steroids in COPD for reasons we'll go through a little bit later. So here are the grim statistics, the world's leading causes of death: ischemic heart disease, stroke, and then COPD, lower respiratory tract infections, and lung cancer. I'll make the point at this juncture here that about half of the patients with COPD die from a heart or circulatory problem, and another large fraction die from cancer of the lung. And so COPD actually sits at a nexus of molecular pathologies that are relevant not only to the lung, but also to heart and circulation and cancer. And of course, again, for creative people, the opportunity might be in the future to use some of the clinical trial strategies that have been developed for early treatment of heart disease. We use antihypertensives, high blood pressure drugs, well before people are in the risk category for strokes to prevent them. Perhaps we can use some of the art there for earlier intervention. It's an interesting proposition. And so COPD is what's called an umbrella term, encompassing emphysema, bronchiolitis, the small airways, and chronic bronchitis, the mucus hypersecretion. In aggregate, COPD. And we think again always of the older people being those who suffer, because I mentioned median age 73. This would be the public perception of COPD, and it's rather sad because people don't care about old people on average. And also in the field of COPD, because the main risk factor on a global basis is cigarette smoking, there is a moralistic bias against people, a prejudice saying, oh, you stupid people, it's your own fault. Why should we even look after you? You smoked and you shouldn't have, therefore you're suffering from this disease, it's your own fault. Now, we don't say that since we know that obesity is a risk factor for breast cancer. It would be unconscionable to say, we're going to withhold your breast cancer treatment because your body mass index is over 30 and you were responsible for that breast cancer. We don't say that for young people who've been drinking a little bit and have a road trauma, or for all of our lifestyle-associated diseases that burden the West. It's particularly the COPD patients because of our effort to reduce smoking, which has led to a moral bias against these poor people. And of course, what people don't realise is that it's not just the young people who suffer, or the old people who suffer. We're now seeing some very fashionable forms of COPD. My favourite is Christy Turlington, the model here, who has supermodel COPD, a combination of anorexia and cigarette smoking, so poor nutrition and cigarette exposure. She actually has emphysema. And of course, the great Amy Winehouse, who was very proud of her COPD before she died from a drug overdose. These are the fashionable incarnations affecting young women. But on a global basis, this prejudice against smokers really leads to lack of attention to the public health problem, which is poor air quality, particularly poor indoor air quality. So for poor people, poor women who prepare food at home in smoky environments using biomass, they're developing COPD in their 30s and 40s and dying very prematurely. So this is an enormous health issue in the developing world. And of course, if you're from one of the Asian countries, but also in Melbourne, deteriorating air quality is now a major contributor to the pathogenesis of COPD. So whereas it was almost 100% cigarette smoking in the past, we're now seeing in some parts of the world up to 25% of the total burden being due to poor air quality. Small particles released from diesel or from our exhausts that irritate the lung and drive the same types of processes. So this is my favourite example of why you shouldn't smoke. It's the one I use for my daughter. On the left of the screen, a rather beautiful picture by Chris Levine that won a prize some years ago. I remember seeing the original in London. It's the Queen there caught in a moment of contemplation. So the Queen now is about 90, leads a very austere lifestyle, drinks almost nothing, doesn't smoke. Her Royal Majesty provided a lovely experiment with her sister, the Princess Margaret, sadly deceased, a wonderful 2-pack a day smoker. And we can see the effect. The Queen, now in her 90s, is still looking rather fine, I think. Princess Margaret here, in her prime, was already wrinkled due to breakdown of elastin in her tissue. This is very important. Suffered lung cancer at the age of 85. It was operated successfully and died from a complex of strokes and probably had emphysema and COPD, although it was never publicly revealed. So I say, darling, these are royal princesses who have, it's my daughter, perfect life, perfect access to health care and perfect food, and this is what smoking does to you. There's the control. There we go. The control, the test, the control, the test. It's a really good experiment. And of course, in the field of smoking cessation, there are 2 arguments to help young people stop smoking that are effective, according to psychologists. For young women, the most compelling argument is it will make you ugly and wrinkled. Wrinkliness caused by cigarette smoking because of elastin breakdown is an unavoidable consequence of smoking, and it's related to COPD, as I'll describe to you. For young men, and this is somewhat gendered, the most compelling argument is because people smoke a lot these days to control body weight. We're all getting heavier. People who stop smoking gain on average 16 kilograms in 1 year. That's how effective nicotine is an appetite suppressant. So I would be very shocked if there were not a few body regulators amongst you. People who think, I'll just have a little puff here because I'm feeling a bit hungry and it'll keep me slim. More and more men are doing this, young men are doing this. And the interesting thing is that if you do that, you will reduce your body weight, but you will preserve your fat and lose muscle. This is the thing, you will be lighter, but what you lose is not the fat. The fat is preserved and made unhealthy and damaging to your health, and you will lose muscle mass and be weak and weedy. Now, a quick visual survey. Most of us are in the happy phase of life here, where our lung function has yet to peak. So when you get your first job and think about your mortgage, this is when life gets a bit complicated. And in the background, the molecular mechanisms that will push us to the grave are already in process. So we're engineered physiologically for our lung function to grow, improve, to about the age of 35. And our normative ageing is over-engineered. We will lose lung function progressively over time. The lung structure physiologically breaks down, but we should be able to live to about 120 with normative ageing and not develop COPD. This is quite important, a famous diagram. It's actually a conceptual diagram produced by Fletcher and Peto, the epidemiologists who discovered the link between smoking and lung cancer. It's called the Fletcher-Peto diagram. Normative ageing and the slow decline and sufficient lung function to be happy forever. The point of disability when most people come first to the doctor, when they're feeling very impaired. The point of death here, probably a little bit higher. The effect of irritants, principally cigarette smoking, in those who are genetically susceptible, and accelerated decline. The benefit of stopping, which is that lung function declines a little bit faster, but it slows, and even if you stop late in life, you may get a benefit. Now, the sad thing is, most people present here when their lung structure is very, very, very damaged, and there is little that can be done except a few mitigations to try and extend their life and reduce suffering. It would be much, much better to have interventions up here to change these disease trajectories to preserve lung structure into the future. And now a huge academic effort to open up how shall we do that? What would the trial endpoints look like? How could we make those types of medicines in the future? Again, I've spoken about the public health need of poor air quality for poor people, biomass fuel and exposure to pollution. There is another really big social justice issue which is becoming apparent through population epidemiology, and this is the effect of poverty on emphysema. So children born to lower socioeconomic families are structurally, quite literally structurally disadvantaged because they very often have small lungs when they're born. This is the aggregate of poor maternal nutrition and very often maternal smoking, which imprints on the developing embryo, the fetus, to retard lung growth. Added to this group here is the increasing fraction of the Western population conceived through assisted reproduction. So very often, assisted reproduction children have smaller lungs at birth, and if they're born prematurely, any child born prematurely before lungs are fully developed will be locked into small lungs from an early age. So these poor people, simply through normative ageing, will eventually hit the symptomatic wall. And so there's another need here to find ways to grow lung tissue safely to raise the bar or to reduce the rate of decline to help these people who are going forward towards really serious problems in the future. And of course, if you start low and smoke or exposed to irritants, there is a compounding risk. These things add up. They're not independent, they're additive. Now, cardiovascular deaths, as I mentioned, kill about half of people with COPD. This is a clever biomarker analysis from Alvar Augusti, a clever chap in Barcelona, a lung physician who's a very excellent researcher, and looking for blood biomarkers that predict risk of cardiovascular disease. So we can see here white blood cells, high sensitivity CRP, which is an inflammatory marker, TNF, which is part of innate immunity and defence, interleukin-8, which is a neutrophil chemotactic factor, interleukin-6, which drives systemic inflammation, and fibrinogen, which predicts cardiovascular risk. Most drug companies are trying to make medicines at the moment that target the neutrophilic inflammation, which is very commonly observed in COPD. And the evidence is, well, you see a whole lot of interleukin-8 produced and a whole lot of TNF-alpha produced in smokers. So this is a very, very false logic. A very false logic. Those medicines, these factors are up as part of host defence against infection. When you block them, you get chest infections. If we look to the actual data in COPD, they're quite small components of disease. And we see major drivers here towards cardiovascular risk. In particular, the increase in white blood cells in general, which reflects drive from the lung to the bone marrow. So I'm going to go through the normal structure of the lung so we can better understand what happens in COPD and the huge problems of trying to make medicines in the future. It's a beautiful cast of the human lung. On the left here, the airways have been infused with an acrylic carefully trimmed to reveal the very small bronchi, as far down as the expert could dissect. And here we see the intersection of the airway structure with the venous circulation in blue and the arterial circulation in red. And obviously the lung is a gas exchange structure, so there must be intimate connection between the circulation and the airways and the gas exchange surfaces. This is very important to understand. The structure here, many branching airways. There are 26 divisions of the human lung during embryogenesis that leads to a very large number of these small airways. Now, I mentioned that the FEV1 measurement that is commonly used sees airways to about here. It does not see changes out here. It is completely blind to here. And actually work that was originally done in Melbourne by the great Lynn Reid in the 60s, now replicated by Jim Hogg, and then again replicated by the COPD Gene Consortium, is really teaching that the primary lesion in the development of COPD is a destruction, a literal destruction of the smallest airways deep in the lung. And we can't yet see that with FDA-agreed lung physiology endpoints. So this is a diagram showing an alveolar unit. Here, the gas exchange surface. We can see the capillaries wrapping around the gas exchange surface, the venous circulation, the arterial circulation here, the in and the out of the blood, not really arterioles, but they're very small capillaries. We can see airway smooth muscle, these bands here, wrapping all the way down to the deepest parts of the lung. And we can see as well in yellow, nerves projecting all the way down to the deep lung. Now, it's always been a mystery why we should have airway smooth muscle so deep in the lung. And there's a really good reason why it turns out from embryogenesis that I'll explain. This is the structure of the normal epithelium in a healthy person. Lots and lots of cilia. Here we can see a raft of mucus. Normally a very thin layer of thin watery mucus sits on the cilia, and the cilia have a very boring job description, which is do this. So don't choose the career of being a cilia. This is your life. You do this. Little molecular hooks, flick the mucus forward, carrying it from the deep lung out. You either cough it or swallow it, and of course this traps bacteria and particulates and helps sweep the lungs clean. COPD directly impairs the cilia. They don't work properly when they're exposed to smoke. Then it kills them. Then it causes a molecular process which causes progenitor cells, so local stem cells, to change their direction, change their career path away from being a cilia into being a secretory cell, a mucus-secreting cell. This is really important because this means that the mucus protection is lost. This encourages infection in the lung and difficulty in clearing muck out of the lung structure. Now, this is an alveolar unit here. We get a very small airway. These alveoli, these are very small airway. We can see little ciliated cells. This is a healthy tissue, a beautiful layer of mucus being cleared. And here we have the alveoli, but they've been stained in a particular way using the stain elastin black. Now, elastin is really important, and you can do this experiment on yourself. I showed you the Royal Princess and Her Majesty, the wrinkliness. So this was explained to me at roughly your age, and I didn't believe that was true, but it is true, and it's very sad. It's how you can see that you're moving slowly from life towards death. It happens to all of us. And you can do it by pinching the skin on the back of your hand. Now, if you have young, fresh skin here, like on this part, it snaps back. But if the elastin has been damaged, in my case, by wonderful holidays in the sun and too much tennis, although I've maintained my youthful good looks, as you can see, oh, it's disgusting. It doesn't snap. All right? So try it. Oh, yeah. This means you're moving along. I'm not a smoker, but if I was, this would be even worse. And you know, this Brad Pitt-like face would be much wrinklier. There are small wrinkles, but you can go into it. Now, the elastin. The alveolar units, just go back, are wrapped in these green elastin fibres, shown green here. They're everywhere. The elastin is really important. The lung is a very elastic organ. If you are in a street fight, because some of you look like bruisers, and you're stabbed in the chest and have a pneumothorax, your lungs will collapse because they're naturally elastic. Okay? Unless you have COPD, then they won't collapse because the elastin's been lost. Now, when we cough or do an FEV1 procedure, so there we go, the air in my small airways was travelling in about 200 kilometres an hour with turbulent flow. To make a cough, you need tremendous compression on the lung instantly to force the air out. Okay? These small airways have no intrinsic structure. They have the consistency of wet plastic wrap that sticks to itself. So the only way you can keep these small airways open is that they must be tethered to the elastin fibres, which behave like little springs. So the little springs in the elastic fibres maintain the patency, the openness, of the smallest airways, which have no intrinsic structure. You can feel the cartilage in your trachea, which holds the big airway open. It's a solid plate of cartilage. We don't have that in deep airways. They're membranous. It's these elastic fibres that do the work. Okay. And the elastin, unless you've been in too much sun, is very stretchy. Does it repeatedly, like little springs. We also have very, very dense microcirculation. So the little diagram underrepresented the density of the microcirculation in the lung. This is a latex cast of an alveolar unit showing the extreme density of the blood vessels, the little capillaries of the alveolar unit. And of course, these are essential for gas exchange. Here we see the microcirculation and the respiratory epithelium in the gas exchanging alveolar unit. We can't see the elastin fibres, they're in there as well. But this is very, very thin. It's a very delicate structure, and of course it has to be because it's a gas exchange surface. If it was thick, gas wouldn't diffuse. It needs to be very, very thin. So this means that these are extremely delicate structures. If blood cells become activated and release destructive oxidants, they will cause damage here, which could lead to the microcirculation dying. And so this is what a beautiful normal lung, small airway, small bronchiole looks like here, allowing gas to be diffused for gas exchange down here in the alveolar units. And we can see along that small airway the thousands and thousands of elastic tethers that keep it open all the way down. So it's not just gas exchange that the alveoli do, they keep these small airways open. And if we trace the elastic fibres through the lung, they form what's called a reticular network, a net-like network, all the way to the pleural surface. And so they stretch one to another, providing elastic recoil to the lung all the way through its structure. And here again we see that to emphasise that the elastic tethers the gas exchange surface. So emphysema, the destruction of lung tissue, very prominent at the top here, less so at the bottom. You can imagine now when all these alveolar units are lost, that these small airways are much more collapsible. This is a huge issue in COPD, and that is not due to an inflammatory process, it's structural. So this is the original work from the brilliant Lynn Reid, who did an experiment in humans and asked them to inhale very microfine tantalum, which is a radio contrast media, and showed that at the earlier stages, these are patients who don't yet have COPD, that the first things that happen, these are alveolar units, is an expansion, a formation of microcysts or small areas of destruction in the terminal airways, which is here. So this area starts to become destroyed and open up. and the elastic fibres are lost. That's the very first thing that happens in COPD, and our current lung function techniques can't see that. They're blind to it. We are, however, developing really good imaging modalities now. And so, for example, you can see here an asymptomatic ex-smoker. We're looking at the lung, CT, so computer tomographic density. There's normally just air in the lung here, but we can register its density very accurately, can measure the airway structure, and then use a number of gases. This one is spin-labelled helium, to look at gas distribution and map the distribution to lung structure. So this person, although was an ex-smoker, has very preserved lung structure and lung function because the gas is being distributed uniformly. This is an asymptomatic but already damaged smoker. So there has been loss of some lung structure, which we can see in the density map. These yellow areas reflect destruction, and you can see on the ventilation map that the lung has uneven ventilation already. So this person is not yet complaining of COPD, has no current symptoms, but you can imagine now that these types of imaging modalities have been created, that they could be used as drug trial endpoints in future trials to preserve lung structure. This is a person who's a current COPD patient who stopped smoking a long time ago, like 20 years ago, but has already destroyed a large amount of lung. So we see in red, these are areas of attenuated structure, loss of structure, a computer mapping system which changes loss of structure into these spherical representations to show where the damage lies mostly. Ventilation, and you can see the damaged areas are very poorly ventilated, and the aggregate here. So this person is well beyond help in terms of trying to preserve structure. It's all about palliation. It'd be wonderful to intervene here. It's very difficult to do anything here. The mouse, the dear little mouse, has been a great friend to us in understanding COPD. Again, the problem of airway destruction and bronchiolitis from the famous Jim Hogg, an immense contributor to the area, because we can study the structure of the mouse lung and molecular mechanisms in great detail, and then map those to human genomics for concordance or translation. And so you can see in the mouse the much simpler structure, but easy to map the lung using high-resolution CT and other construction mechanisms and do ventilation perfusion. And here's a mouse lung where emphysema has been induced artificially by instilling an elastin-destroying enzyme, pancreatic elastase. Okay, so you can see the normal lung, regions of destruction, and here in the really destroyed lung, this phenomenon of hyperinflation. So the lung is now, because it's lost elastic fibres, it no longer has recoil, it's become hyperinflated, okay? And it won't easily deflate because it can't, because it doesn't have the elastic fibres. And so if we map force maps onto the lung, one of my students did this rather beautifully, Andrew Lilia, a normal airway with the many alveolar connections, an emphysematous airway, which is also fibrotic and has mucus in it, the three components of airflow limitation. During expiration, in the normal lung, the forces are always pulling on the airways, even during intense compression, to keep the small airway open. It's not the case in COPD. The airways collapse very easily, and this causes hyperinflation. And this is particularly prominent in COPD patients when they start to exercise. There is a phenomenon of dynamic hyperinflation. So now, for the fun of it, we can do instant asthma and instant COPD. So I would imagine there are a number of people who have or know asthmatic, are asthmatic or know asthmatics. A simple way to get a little bit of the feeling of being asthmatic is to make a little opening here and breathe through a restriction. It's an unpleasant sensation. And then we take the miracle formoterol, which I helped to develop, spray it. the airways open up, reversible airflow limitation. Okay? Now COPD, do that, add the restriction, but now breathe in as far as you can first. Total lung capacity, and now try and breathe through this restriction without breathing out. And see how long you can do it for. Maybe 3 or 4 breaths, it's already very unpleasant. So that is the daily life of a COPD patient. And again, breathe the total lung capacity, and then add in the spray. There's a little bit of relief initially, but you don't deal with the big problem. Okay? So this is how the drugs work in the disease. Really terrible. If you survey patients with most serious conditions and ask them, what would you like from your treatment? Something that's a fatal condition. They almost always say, I don't want to die. COPD patients in those surveys never identify prolongation of life as a therapeutic goal because it is so unpleasant to live with that chronic breathlessness. They do not want to live longer. They ask for, I don't want to be breathless and I want to be able to do normal activities again. They're the 2 things that come out of all the surveys, not life extension. And you can see just in a few seconds how horribly unpleasant that sensation is. And that, if you can't escape from that, if that is your life every day, you can see why COPD also tracks with depression, a lot of emotional problems. Okay, so we're now developing clever ways of understanding how COPD develops. And I just want to make the point, we'll be talking about molecular pathways a little bit towards emphysema, but there is a certain stage when the elastic fibres are so weakened that simply physical breathing, particularly during a chest infection when there's extra force on the lung, causes the tissue to rip. So there'll be mechanisms which are molecular, but when the strength and elastic fibres are lost, the lung tissue can simply rip physically, causing emphysema progression. And this, of course, is not tractable to a therapeutic intervention. This was proposed by the Australian Jeff McClellan, who died recently, a very wonderful person, and has now been proven to be true. There's a paper this week in the American Journal of Respiratory Disease. So if we look to COPD as well, this is Albrecht Dürer's drawing here of himself with a liver problem. It's just a reason to put a nice drawing in. These are the problems that COPD patients have apart from their chronic breathlessness. They get repeat viral and bacterial infections. I've mentioned wrinkling, but very poor wound healing, are prone to diabetes, have generally attenuated immunity, which compounds with infection risk, but also other problems. Of course, are depressed and are addicted to nicotine. Very high prevalence of cardiovascular disease, often lose teeth because of the way that smoke destroys oral defence. Very commonly are osteoporotic and have lost a lot of muscle. Develop cancers very commonly as well. It's from a review Martin Stampley and I wrote some years ago in Nature Immunology. And so from the mouse models, we've learned a lot about how COPD develops. An inflammatory insult inhaled into the lung, normal lung here, small airway, blood vessel, alveolar units. Even in the first few days of exposure, you see accumulation of inflammatory cells and changes in the epithelium towards hypersecretion. This happens within 4 days of exposure. And transdifferentiation of the epithelium away from ciliated towards mucus secreting. And so the simplest model of COPD pathogenesis is, as I mentioned, smoke causing inflammation, inflammatory cells which release oxidants, cytokines, proteases and growth factors and lead to these pathologies. And I want to again point out the big problem here, which is that companies have said, oh, that's the mechanism, we'll just make anti-inflammatory agents. Now, these have all been done. There have been many, many failed trials with anti-inflammatory agents in COPD, mostly because they're trialled in people in their 70s, when the lung structure is gone, so this process is finished. It's finished. and also the immunity is weakened, and the patients have colonisation of the lung with bacteria. So when you do these types of strategies in late disease, there is no benefit on emphysema, and the people get chest infections, because blocking these pathways in late disease further worsens host defence. Really false logic. This may be a viable option used in people in the early phase when the disease is active. If we do the transcriptomics, look at all the factors that are being produced in late stage disease, it is remarkable that nothing is happening. You do not find upregulation of inflammatory genes, you find almost nothing. It's transcriptionally almost silent. The tissue is almost dead. So there's no active process really here to remediate. We have to go much, much earlier. And maybe these strategies will work in people in their 40s and 50s, but they definitely don't work in people in their 70s. And so I've summarised here all the known mechanisms of emphysema development. There is the small lung problem. There is an issue around how tissue regulates proteases in conjunction with TGF-beta, which is in the lung tissue a fibrotic mediator, but also a regulator of fibrosis. There is possibly an autoimmune mechanism in late disease where autoantibodies are formed that attack the lung structure. And a large part of the problem turns out to be destruction of the microcirculation, the little tiny capillaries. At least 4 or 5 molecular processes have been found here. And when these small microcirculation capillaries die, it causes the adjacent airway alveolar unit to die, leading to microlesions that add up to aggregate holes in the lung. And then, of course, we have the genetics of the susceptibility. We know from population studies that if you don't defend yourself well from oxidants, this accelerates things. If you have unfortunate enzyme variants in the epithelium which transform chemicals in smoke from less dangerous to more dangerous, these are some of the epoxide transferases, that you're in a bad situation. In genomic studies, the biggest single gene signal for COPD risk is in the brain. Nicotine addiction propensity. The nicotine receptor comes up as the #1 strongest universal locus for COPD risk, which suggests that dealing with nicotine addiction would be a really good thing on a population basis. There are defects in what is called catabasis. Catabasis is the normal healing response that takes damaged tissue and restores it to health. Smoke just ruins normal resolution. Links to vitamin D, and I've mentioned over a number of times the immune defects. Okay, and McClelland's theory of physical trauma, which is now proven. So we'll come to a little bit to the therapeutics. We'll go to the hour, then stop, and tomorrow we'll just pick this up, continue. The drugs that are used to treat COPD are asthma drugs, repurposed. And so we have bronchodilators, principally the anticholinergics. So in the field of COPD, anticholinergics are used as first-line therapy, and they're very often combined with a beta agonist, a long-acting beta agonist. There are a lot of these. It's a huge global problem. There are many drugs all doing the same thing, of blocking muscarinic receptors, M3 receptors to bronchodilate, or activating beta-2 receptors, or in combination. Methylxanthines are sometimes used, very poorly effective, and there's one drug which is a phosphodiesterase 4 inhibitor called roflumilast, which is used in hypersecretory COPD, sort of niche indication. Big controversy around the role of steroids in COPD. So steroids are very much a double-edged weapon in COPD. The best evidence, which is from Ian Pavord's group in Oxford, is that if a patient has eosinophils in the blood or lung, which is a trait we normally associate with asthma, so this is an ACO-like trait, then they will respond reasonably well to steroids and get a therapeutic benefit. providing the eosinophil number goes down in response to the steroids. So if you have eosinophils and they go down, that's a good aggregate for using steroids in those patients. However, steroids are used very, very widely in COPD, particularly now because they're packaged in triple therapies, which is an anticholinergic, a long-acting beta agonist, and a steroid in one canister. And they're probably overprescribed. So if patients don't have this eosinophilic trait and a history of exacerbations, then adding the steroid in simply suppresses their local immunity, and there is very, very clear evidence now that that increases the chest infection rate and the pneumonia rate in these patients because it compromises host defence. Vaccinations are recommended, but again, immunity is very weak in COPD, and influenza and Haemophilus vaccines, which are standard of care, do not work particularly well in the patients. So we'll talk a little bit about therapeutics, and I won't go through all of them, but rather focus on the anticholinergics. So the story of this is just beautiful. Lowy, 1921 in Germany, performed a classic experiment where he had two organs, two beating hearts in series, and he stimulated this heart, the parasympathetic fibres, which was known to slow the heart rate. That was known, and by stimulating the vagus nerve. And the heart released a substance which slowed the second heart, initially called vagus stuff, the stuff or the substance from the vagus. Prussian science in the day was pretty good. It was very rapidly chemically identified as acetylcholine, which is the molecular basis for cholinergic neurotransmission. It was realised very quickly, mostly by German, but also English physiology, that acetylcholine biology could be mimicked by two known poisons, nicotine and muscarine, giving us the concept that acetylcholine activates nicotinic receptors, but also muscarinic receptors. And it was also realised very, very quickly that another poison, atropine, exerted its effect by blocking the effect of acetylcholine on muscarinic receptors. This was worked out, chop, 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 in the 1920s. Beautiful classic science. The sad part about this in the German context is the VX nerve gases that were developed to inhibit the breakdown of acetylcholine later on. That's a side story. And historically, actually, inhalation of datura stramonium, but also atropine-like cigarettes, had been used for a long time, actually since Egyptian times, Roman times, to treat airflow limitation, burning these alkaloids from plants that had atropine or atropine-like substances. And in fact, you could buy asthma cigarettes well into the 1940s, also used to treat COPD. Now, this is a very problematic, very famous paper, the Gross paper, 1984, because it set the distinction between asthma and COPD. Published in the most prestigious journal, the New England Journal of Medicine. Gross proposed, based on good quality research, that COPD patients preferentially benefited from an anticholinergic agent, but responded poorly to the newly developed beta agonists, salbutamol, which was introduced into clinical practice in 1979, so a very fresh drug at that time. And this set the concept that the parasympathetic activity is the dominant activity in the COPD lung. Now, would question that now, based on current knowledge, but this has set the tone that you treat COPD with anticholinergics and you treat asthma with beta agonists. This was set in the 1980s, a very fixed concept. I've got time for a few more slides. Now, if we go down and take a look at those fibres in the deep lung that I showed you earlier on, we see that there are a lot of nerve fibres in the human lung. If we go to the small bronchi, they are predominantly cholinergic fibres. So those yellow projections that went down to the alveolar units in the diagram I showed you are predominantly cholinergic, which release acetylcholine, which contracts airway smooth muscle through the muscarinic 3 receptor. And this is very interesting. It's been discovered, actually, by Malcolm Sparrow in Australia,